This program is about care of the patient with a pump. After completing this lesson, you will be able to describe 2 points of care for the patient during administration of an intravenous solution. Describe 2 precautions related to the infusion pump. Name 2 complications of infusion therapy. Describe 2 points of care for the patient on enteral nutrition, and describe 1 way to prevent aspiration for the patient on enteral nutrition.
Let's take a trip back in time. The year is 1965. The Sound of Music is the best picture of the year. The Mustang is the hot new car on the block. Miniskirts are making their debut. And 18-year-old John Williams is a patient at Community General Hospital in northern Wisconsin. He was water skiing when he lost his grip on the tow rope and wrapped himself around a pier, sustaining 4 broken toes, a broken ankle, and a serious laceration of his left calf. A major infection developed from the laceration. John will be in the hospital for at least another 10 days, receiving intravenous antibiotic therapy. John spends most of his time alone. The hospital is over 50 miles from his home, too far for visitors to travel on a regular basis. Because of that, John is falling behind in his classes. With his high school graduation a little over a month away, he is worried that he may not graduate with his class. Technology in the 60s for patients with cancer, nutritional problems, dehydration, and similar conditions often meant hospitalization. Intravenous therapy involved a reinsertion of the needle every 2 to 3 days, leaving the patient bruised and sore. A patient undergoing chemotherapy was usually hospitalized and received 1 massive dose of the medication, often creating many side effects. The patient in chronic pain was at the mercy of the clock. The pain medication could only be administered every 4 hours. Needless to say, the technology was not very patient-friendly. Now let's fast forward 25 years to check in with John Williams, Jr. He holds onto the tow rope just like his father did. And like his father, John Jr. ran aground on a pier, breaking several toes, tearing some ligaments and tendons, and sustaining a severe deep cut. And he developed a serious infection that requires antibiotic therapy. However, John Jr. is not in the hospital. He is in the comfort of his own home. John receives antibiotic therapy with a pump. He plans to graduate with his high school class. Like father, like son? Hardly. Recent advances in technology and the development of pumps allow patients to be treated at home for many conditions which would have required hospitalization in the 60s. While most high-tech pump therapy today follows an early discharge from the hospital, more is being initiated following an outpatient assessment or procedure, as an alternative to hospitalization. A pump is a safe, reliable way to administer medications and fluids in the home. Physicians are more confident about treating their patients at home because of a proven track record for safety and patient compliance. Insurance companies and care planners recognize the potential for cost savings and patient satisfaction. And patients wholeheartedly approve. There is no place like home, especially when illness strikes. As more complex therapies move into the home, the need for education about the care of the patient with a pump becomes increasingly more important. Because of the nature of the patient's disease or injury, these patients often require assistance with personal care needs. Even though the registered nurse remains responsible for the therapy and medication, other caregivers are entering the picture. Home health aides and nursing assistants, personal care workers, hospice volunteers, and family members are called upon to meet the patient's needs without interfering with the pump and therapy. They must know about necessary safety factors and precautions and make important observations. This program will focus on how to adapt care delivery to meet the needs of the patient with the pump safely without interference to the therapy. First, let's look at the types of therapy which can be provided in the home with a pump. There are 7 types of therapy: cardiotonic therapy, hydration, antibiotic therapy, chemotherapy, pain management, and nutritional therapy, which includes total parenteral nutrition, known as TPN, and enteral nutrition. The first 6 therapies are called infusion therapies. We will discuss those first, saving enteral nutrition for later. Infusion therapy involves the injection or infusion of medication directly into the veins. The intravenous or IV route is a safe and efficient means of sending drugs and fluids through the body. This route of administration is faster and more effective for many medications than taking them by mouth or an injection into the arm or buttock. Infusion therapy means less discomfort and fewer hazards and complications. Sterile needles are used only for the patient, so there is no risk to the patient of catching AIDS or hepatitis from the IV needles. Cardiotonic therapy is usually used for patients in severe congestive heart failure, or CHF. Cardiotonic therapy may also be ordered for the patient in the final days of life, or for the patient awaiting a heart transplant. Home hydration therapy replaces fluids lost by patients who are severely dehydrated from prolonged vomiting or diarrhea and cannot take in enough fluids orally. Patients experiencing severe morning sickness, side effects from chemotherapy, or severe flu may receive home hydration therapy for short periods. Intravenous infusion of antibiotics is used in patients with severe infections when oral medications would not be effective or when long-term therapy is indicated. Usually the patient is treated at home if the only reason for being hospitalized would be to receive the antibiotic therapy, as in the case of John Williams, Jr. Some of the conditions treated at home include complicated urinary tract infections and pyelonephritis, kidney infections, postoperative wound infections and abscesses, osteomyelitis, infection of the bone, and cystic fibrosis in adults and children. Chemotherapy is the use of medicine or drugs to kill cancer cells. An infusion pump allows the patient to receive small, constant doses of the chemotherapy medication over several days instead of receiving one dose, called a bolus, in the hospital or outpatient department. Patients generally tolerate smaller doses better and may experience fewer side effects. Pain management programs are frequently used for patients who experience chronic intractable pain due to cancer, sickle cell anemia, or terminal illness, or those who experience acute pain after major surgery or in cases of osteomyelitis. With the patient-controlled analgesia pump, also called the PCA pump, the patient receives a continuous infusion of a narcotic analgesic or pain-killing medication. The patient can also push a button to self-administer a bolus or larger dose of the medication when the pain is more severe. The nurse programs the pump to dispense the medication according to the physician's instructions. Built-in safeguards prevent accidental or intentional overdosing. The patient requires less narcotic medication and achieves better control of the pain with less sedation. Total parenteral nutrition, also called TPN or hyperalimentation, is intravenous administration of a nutritionally complete formula. Those who require TPN include patients who cannot absorb the nutrients through the gastrointestinal tract, such as those patients with short bowel syndrome or radiation enteritis. Patients who have a need for complete rest of the bowel, as in cases of inflammatory bowel disease or pancreatitis. And patients who require supplemental nutrition to promote healing and recovery, those with severe burns or metastatic cancer with severe loss of appetite. Before the patient begins infusion therapy with a pump at home, the physician and home care team must make sure that the patient is an appropriate candidate. First, there must be a competent person who understands the purpose and techniques of the pump and can assume responsibility. This can be the patient, a family member, or a private duty nurse. The home care team wants to ensure that there is adequate psychological and social support available to the patient and that there is little chance of equipment or medication abuse or risk of damage to the supplies and equipment. Adequate financial resources must be available to cover the cost of the infusion equipment, supplies, and medications. The home environment must be appropriate. There must be running water and a safe, dry, and clean area for storage of medications and supplies. Refrigeration should be available if needed for medications and nutritional supplies. And there should be a telephone, proper electrical outlets available, and room to move about with the equipment. The physician and the home care team decided that John Jr. was an appropriate candidate for infusion therapy at home. Even though his ambulation is restricted, the only real reason for hospitalization would be to receive the antibiotics. John lives with his parents, who will assume responsibility for the infusion therapy. Because John's parents work, John will receive assistance during the day from a home care RN and a home health aide. Before we talk about infusion therapy, let's identify some very important precautions. The home care registered nurse and the physician are in charge of the pump programming, settings, and therapy regimen. The nurse teaches the patient or a private caregiver, a family member or friend, how to start and maintain the infusions and care for the pump, along with basic troubleshooting techniques. In the home, the patient or private caregiver is in charge of the pump and medications. During this program, we will show you how to care for the patient while not disturbing the pump. We will also discuss your role in emergency situations. Just remember, never adjust the settings, rates, or any of the controls on the pump. Never disconnect the solution from the pump. Have emergency numbers of the home care RN and caregiver available. Your nursing instructor or RN supervisor will familiarize you with your particular agency policy and procedure. To care for the patient receiving infusion therapy with a pump at home, you must have a basic knowledge of the system, specifically the insertion site, the rate of flow of the solution, and the pump. These factors influence the care you provide. The insertion site is the place where the intravenous line is inserted. A peripheral site is in peripheral veins, the veins most distant from your heart. If you look at your arm or hand, you can see many peripheral veins, bluish in color. These peripheral veins are easiest to find. The hand has the smallest peripheral veins and are the easiest to enter. The larger veins in the forearm are the ones usually used in home infusion therapy. The peripheral IV line can usually be inserted by the registered nurse in the home setting. Because of the location, these lines need to be removed and reinserted every 3 days and are usually used for short-term infusion therapy. If your patient has a peripheral line, it will be covered with a dressing to help prevent infection. Protect the site so it stays clean and dry. Avoid tugging or jarring of the line. Excessive trauma to the vein may cause an infection, obstruction, or dislodgement of the line. The second place the IV line can be inserted is in the central veins. These veins are closer to your heart and can transport greater volumes of solution than the smaller peripheral veins in the hands and arms. Central lines can stay in place longer and are used for long-term therapy. The central line requires insertion by a physician, usually in the hospital setting, using a local anesthetic for insertion. Protect the central line site during care delivery. The patient must always keep a dressing over the central line site. Do not remove this dressing. The nurse will teach the patient or family member how to clean the site using an antiseptic and change the dressing, following the procedure as ordered by the physician. The physician will give instructions regarding bathing and personal care. The condition of the patient's veins, the amount and types of fluids and medications he or she must receive, the intended length of the therapy, and the availability of support services will determine if a peripheral or central line is used. Peripheral veins are generally used for short-term infusion therapy. Central lines are for longer-term therapy, therapy with larger volumes, or with irritating solutions or medications. After the IV line is inserted, it is connected to a tubing which leads to the pump for administration of solutions and medications. The rate of infusion may be intermittent or continuous. Intermittent administration means that the IV line is connected to the pump for a specified period of time on a schedule to permit the administration of the medications and solutions. The patient, family member, or the nurse will connect the IV line to the solution and set the rate on the pump. After the infusion is finished, the patient, nurse, or family member will disconnect the solution and flush and cap the line, which means injecting a flushing solution which keeps the line from clotting, so it can be used again. Care delivery is simpler for the patient on intermittent administration. In most cases, bathing, exercising, and ambulation can wait until the solution has been administered. After the pump is disconnected, you can assist the patient to shower or bathe. Your care plan will probably provide instructions to protect the IV site with a plastic occlusive cover. Continuous therapy means the solution runs all the time. The patient on continuous infusion must receive care while the IV line is attached to the pump. You must know how to modify care delivery to protect the line and assure uninterrupted flow. Discuss with your supervisor any need for special clothing with snaps along the arm. It is very difficult to fit a shirt or pajama top over the pump on a pole. Precautions which apply to the patient on continuous infusion also apply to the patient on intermittent administration who requires care while the solution is infusing. Protect the IV site. Keep the dressing dry. Know where the intravenous tubing is at all times. This will prevent any accidental pressure or tugging on the line. When you assist the patient to reposition, leave enough slack in the tubing so there is no pulling. The patient should not lay on the tubing. This could cause obstruction in the flow. Let's take a minute to look back at John Sr. in the hospital. In the 60s, there were no infusion pumps, and problems in care delivery were numerous. The nurse would prepare the infusion in a glass IV bottle. She would calculate the number of milliliters needed per hour to get the rate of infusion as ordered by the physician. Then, she would mark a strip of tape indicating how much solution should be gone by a certain time, and place it on the bottle to monitor the infusion and be sure it was on schedule. Finally, the nurse would calculate the number of drips per minute needed to maintain that schedule, and set the infusion by using a roller clamp on the tubing. Needless to say, the system was far from precise. The slightest movement by the patient could change the rate. The solution might stop dripping, leading to an obstruction of the IV line. Or the solution might start to pour into the vein, overloading the patient with fluid and medication. The nurse would come into the room and check the IV only to see that it had stopped or was empty. Either way, the patient did not get the medication as ordered, so the therapy was not as effective as desired. Now, in the 90s, advanced technology offers the benefits of infusion pumps. An infusion pump is an electronic device that exerts pressure on the tubing or fluid to maintain a constant, pre-selected rate of administration of solutions and medications. Home infusion pumps are lightweight, reliable, accurate, and cost-effective. The pumps are easy to use. Almost all of them have digital displays. Programming the pump, entering the information needed to maintain the infusion rate, is as simple as programming a VCR or microwave oven. The digital readouts also communicate vital information to the nurse or caregiver, such as the rate of infusion and medication administration. The pumps have many safety features. These features guard against disconnections and accidental free flows, that is, solution running into a vein uncontrolled. Some pumps offer the lockout capability, so the child or confused patient cannot change the settings. Others, like the patient-controlled analgesia pump, have number codes which permit only the nurse or physician to program the pump. All pumps have built-in backup batteries, which automatically begin functioning in case the pump is accidentally unplugged or there is a power failure. There are two types of infusion pumps. A portable pump, which includes rechargeable batteries, is often small enough to fit in the palm of the hand. It can be carried in a pouch on the waist, or back or under the arm, enabling the patient to be up and about. The patient who uses the portable pump can be more active, and he will probably need minimal assistance. However, if you do care for the patient with a portable pump, remember these precautions. Do not drop, jar, or bang the pump. Do not submerge the pump in water. The registered nurse will give you special instructions on how to protect the dressing and site, and how to assist your patient with bathing and other activities. The second type of pump is lightweight, hangs on a pole, and is usually plugged into an outlet. This pump is used for the patient who is non-ambulatory or has limited ambulation, and for the patient on intermittent infusion. This is the type of pump John Jr. is using at home to receive intermittent administration of antibiotics through a peripheral line. He cannot bear weight on his right foot because of the injuries, so the doctor has ordered bed rest with bathroom privileges. Nancy, the registered nurse, has assigned Norma to help John with personal care activities, such as a bath and oral hygiene. Norma will also assist John to the bathroom. Because Mrs. Williams started the antibiotic infusion before leaving for work, Norma will care for John while the solution is infusing. As Norma assists John to reposition, she recalls the precautions she learned about. Always know where the tubing is. Allow enough slack in the tubing so there is no pressure on the line. If necessary, Norma will move the pole to the other side of the bed, always keeping a watchful eye on the tubing. Things do not always go as smoothly as planned for the patient on a pump. That is why you must be aware of some of the situations which could develop and what you can do. Most pumps have a built-in alarm which serve as a warning that something is wrong. The patient or caregiver is trained to respond to these alarms. The alarm can mean many things. Check first for occlusion or obstruction of the line, in which case there will be no solution dripping into the drip chamber. Obstruction can happen when the patient is lying on the tubing is kinked, or the patient's arm is in such a position that blood backs up into the tubing. Reposition the patient's arm, straighten any kinks in the tubing. The patient or caregiver will turn off the alarm and reset the pump. If temporary occlusion was the problem, the alarm will not sound. However, if the alarm continues, contact the RN. The alarm can also mean air in the line. A small amount of air, such as a few bubbles, will not be harmful and occurs naturally. A large amount of air, such as several inches, needs to be removed by the patient or family caregiver, who will disconnect the tubing and clear the line. If the low battery alarm sounds on the pump on a pole, plug the machine in and notify the RN. If the alarm sounds on a portable pump, contact the RN to check the batteries. Norma will assist John to transfer into the wheelchair, and then wheel John and the pole into the bathroom. Before beginning this task, Norma evaluates any risk factors. John cannot bear weight on his right foot. She checks for any potential obstructions in their path, such as carpeting, low door frames, ceiling fans, or chandeliers. She will explain the procedure to John before beginning the transfer, so he does not bear weight on his injured foot. And she will keep a watchful eye on the tubing. Norma has also been taught about some complications which may develop during care delivery. If there is swelling, redness at the insertion site, oozing or pus on the dressing, or if the patient complains of pain or irritation or has a fever, this can mean infection. Because infection can lead to obstruction, report this to the registered nurse. If the patient complains of pain or burning at the insertion site, or if you notice swelling, the line may have slipped out of the vein, causing infiltration or seepage of the fluid into tissues instead of flowing into the vein. Again, report this to the RN. If the dressings over the insertion site are wet, this means that fluid is leaking. The patient or family caregiver should check all connections. If there are no loose connections, that means there may be another problem, so notify the nurse. If the catheter or tubing breaks or becomes disconnected from the patient with the central line, there is danger that air bubbles will enter the vein. There may be oozing of blood. The patient or caregiver must immediately clamp the line and call the nurse or physician. If the catheter pulls out of the chest, hold pressure over the site and notify the nurse immediately. Proper protection and handling of the IV line can prevent the catheter from breaking, disconnecting, or pulling out of the chest. With careful planning and management of time, Norma has completed the assigned duties safely and efficiently, just in time for Nancy's arrival. Nancy will disconnect the solution and cap the line. Then Norma can assist John to put on clean clothes. The role of the home health aide or caregiver goes beyond the personal care of the patient. There are measures you can take which are important for patients on infusion therapy. Take the temperature of the patient every visit. Often an elevated temperature is the first sign of infection at the insertion site. Also observe the site for any redness or signs of infection. Document and report any pertinent observation to the nurse. Monitor intake and output as needed. Observe good infection control practices, especially hand washing and disposal of dressings. Check your care plan for special care related to the patient's diagnosis. Let's stop to review some important points about infusion therapy. What is a peripheral line? What is a central line? Can you name 3 precautions to observe while an intravenous solution is infusing? Can you adjust settings on the pump or disconnect solutions? How can you respond to a pump alarm? John is working hard to keep up with his high school classes. We'll let him study now as we meet another patient and discuss the second type of nutritional therapy performed with a pump in the home. Enteral nutrition is the delivery of nutrients directly into the gastrointestinal tract. Remember, TPN is intravenous therapy, nutrients going directly into a vein. Enteral nutrition is necessary for the patient who has a functioning gastrointestinal system but is unable to eat and/or swallow. That means that the patient can absorb the nutrients from the food into the stomach and intestines but cannot take food in through the mouth. People who receive enteral nutrition fall into 3 groups. The first group includes those who experience impairment of the swallowing and gag reflex due to central nervous system disorders such as coma, cerebral vascular accident or stroke, multiple sclerosis, head trauma, or congenital abnormalities like cleft palate. The second group is those who cannot meet their nutritional requirements through oral intake alone, such as patients who are malnourished because of a limited intake due to an underlying illness, chronic malnutrition, or old age. The last group includes those patients who are unable to eat but have no impairment of the swallowing or gag reflexes, such as the ventilator-dependent patient and the patient with a broken jaw or a tracheostomy. As with infusion therapy, The physician and home care team must decide if the patient is an appropriate candidate for enteral nutrition at home and will look at many of the same requirements as an infusion therapy. There must be a competent person to assume responsibility, adequate psychological and social support available to the patient, an appropriate environment, and adequate financial resources. Agnes Brown has been a patient of the Home Health Agency for almost a year. She had suffered a stroke last year and was doing well in her apartment with assistance from a home health aide. However, her ambulation was still affected by the stroke. When walking outdoors, she lost her balance and fell, sustaining a broken hip and jaw. Agnes is on enteral nutrition for a short time because her jaw is wired and she is unable to eat. She is staying with her daughter Linda, who has been taught to do the enteral feedings. The role of the home health aide in enteral nutrition varies greatly from agency to agency. This program will discuss important points of care for the patient on enteral nutrition. Your instructor will explain your duties and agency policy. Enteral nutrition is administered through a nasogastric or NG tube placed through the patient's nose and leading into the stomach. A nasogastric tube is the least expensive method of enteral nutrition and the easiest to insert. The nurse can insert the tube in the home. However, the NG tube can become dislodged and move out of the stomach. Some patients find the tube uncomfortable and are bothered by its appearance. Enteral nutrition can also be administered through a tube surgically placed in the patient's abdomen. It is called a gastrostomy tube or G tube if it goes into the stomach, and a jejunostomy tube or J tube if it goes into the small intestines. The insertion site is called a stoma. The gastrostomy and jejunostomy tubes are for long-term therapy. These tubes are generally less difficult to maintain and pose less risk than the NG tube, but they must be inserted in a hospital facility, often utilizing local anesthetic during the procedure. The physician will prescribe the composition of nutrients in the formula for enteral feedings, the fluid requirements, and the administration schedule. The patient or family caregiver will prepare the formula according to the prescription. It is possible to make a formula from scratch in the home using a blender. However, most enteral feedings use commercially prepared products, sterile canned or bottled liquids, powdered or concentrated products. Some liquids can be administered simply by opening a can. Others require mixing. Because the formula is an excellent media for the growth of germs, one of the biggest concerns with enteral nutrition is microbial contamination of the formula and equipment. All commercial enteral products are prepared under sterile conditions. Here are some safety guidelines to follow to prevent contamination. Follow the manufacturer's guidelines for storage of the product. Store in a cool, dry, clean area or in the refrigerator if required. Do not use products which have exceeded the use before date. Wash your hands before handling any formula or supplies. Prepare only enough formula for 1 day's administration. Cover opened unused product and label with date and time opened. Discard unused open product within 24 hours or according to the manufacturer's guidelines. Check all feedings carefully for signs of thickening, lumps, or separation, which may indicate microbial contamination. Do not leave the formula hanging in the pump longer than the scheduled time of administration. Rinse the container and tubing well with hot water after administration. Allow the container and tubing to air dry completely. When dry, store the equipment in a clean covered box or wrap in a clean towel. Change equipment as recommended by the nurse or your agency's policy. Before beginning the feeding through an NG tube, the patient or caregiver may have to check the gastric residual, which is the amount of liquid and tube feeding left undigested in the stomach. This will also determine if the tip of the tube is properly placed in the stomach. If there is too much liquid in the stomach, the feeding may be held or reduced to prevent vomiting and gastrointestinal distress. This will depend on the doctor's instructions. After checking the gastric residual and placement of the tube, it is time to administer the feeding. We have already discussed how to prepare the formula for administration using aseptic techniques. Here are some other points to remember. Before administering the formula, Linda assists Agnes to sit up in a chair. Agnes could also be sitting in bed, with the head of the bed elevated at least 30 degrees. Before beginning, Linda washes her hands. She prepares the formula, fills the feeding container with the amount of formula ordered by the physician, Then Linda attaches the tubing to the pump, opens the clamp if there is one, and sets the pump to the appropriate rate. When the feeding is finished, Linda rinses the tubing with water, disconnects the pump from the feeding tube, and clamps the tube until the next feeding. Agnes should not lie flat for at least 1 hour. Health and comfort of the patient depend on proper care of the insertion site. If your patient has an NG tube, the tube will be taped to the cheek and the nose. The tape on the cheek and the nose should be changed at least every other day, or more often if it becomes loose. If you are assigned to change the tape, your care plan will include specific details. Be sure to gather the necessary supplies before you begin. Hold the tape securely in place and gently remove the old tape. Wash the skin with soap and warm water. Be careful that you do not displace the tube. Check for any signs of irritation or ulceration. Rinse well and pat dry. Gently drape a section of the tube over the same side of the face as the nostril that contains the tube. Be sure that the tube does not rub against or pull on either nostril. To retape the nose, cut 2 pieces of tape, one 3 inches, the other about 1.5 inches. Cut the 3-inch strip halfway down the center. Place the wide part of the strip over the bridge of the nose. Wrap the 2 tails alternately around the tube. Place the second piece of tape over the bridge of the nose. Don't let the tube kink or tape it too tightly. Oral and nasal hygiene are also important. Clean the edges of both nostrils at least once a day using a cotton swab that has been moistened with warm water. Your supervisor may instruct you to use hydrogen peroxide mixed with equal parts of water to remove dried secretions. Apply a water-soluble lubricant, such as KY jelly, around the tube inside the nares. Never use a petroleum jelly or any oily products around the nostrils. Report any bleeding, redness, or patient complaints of numbness to the nurse. Assist the patient to brush gums, teeth, and tongue at least twice a day using a regular toothpaste and toothbrush. The patient can use a mouthwash to freshen the mouth and breath. Use a lanolin-type moisturizer on the lips to prevent chapping. Because Agnes's jaw is wired, she rinses with a hydrogen peroxide solution several times a day and uses a toothbrush on the outer gum and teeth surfaces. Your care plan will indicate if the patient can chew gum or take anything by mouth. For a gastrostomy or jejunostomy tube, the patient will also need skin care at the insertion site or stoma. If the insertion site is not yet healed, the nurse will probably perform the dressing change. When the site is healed, you may be assigned to cleanse the skin. Follow these steps. Remove the old dressing if one is used. Dispose of it properly and wash your hands. Use a clean cloth, mild soap, and warm water. Wash with a circular motion, beginning next to the insertion site, also called a stoma. Do not pull on the tube. Rinse the skin with warm water and dry well. The physician may have prescribed an ointment to be applied on the skin around the tube or a dressing to protect the site. Your nursing supervisor will demonstrate the application of the ointment and dressing. Check for any redness, leakage, or drainage around the stoma, or any rash or pimples on the abdomen. Document and report any problems to the nurse. The patient on enteral feedings may be more susceptible to thrush, which is a yeast infection of the mouth. Inspect the mouth daily for any white patches. Be sure to provide good mouth care. Practice good infection control techniques. The feeding pump has an alarm that may sound when the feeding tube becomes clogged. The tube may clog for many reasons. A kink or bend in the tube, formula that is too thick, or medications or formula that have not been flushed through completely. Medications can contribute to this problem because they are very sticky and thick. The nurse or caregiver may have to irrigate the tube. If the obstruction cannot be removed, a new tube must be inserted. Blockage of the feeding tube can be prevented if the caregiver flushes the tubing after each feeding. The patient may experience problems related to the enteral nutrition. There are some care delivery strategies you can employ to minimize or prevent the problems. Aspiration can be a serious consequence of enteral feedings. Aspiration is the accidental inhalation of some of the feeding into the lungs, very similar to swallowing something down the wrong pipe. Regurgitating small amounts of formula or vomiting can also cause aspiration. Following a few simple rules can almost eliminate the possibility of aspiration. Before administration, the person who administers the feeding must check for gastric residual to ensure that the stomach is empty and the tube is in the proper place. Avoid administration of the feeding if the patient complains of a feeling of fullness, sickness in the stomach, or vomiting. The patient should be in a sitting position during the feeding and for at least 1 hour after. If the patient begins to choke or have breathing difficulties during the feeding, stop the feeding immediately. Keep the patient sitting or in a side-lying position while you call for assistance. The patient will experience looser stools on enteral nutrition because this type of feeding provides less fiber than solid food. Loose stools may not necessarily mean diarrhea. Diarrhea is frequent loose or watery stools that occur with increased frequency. The patient may also experience abdominal cramping, churning, fullness, nausea, and weakness. Report episodes of diarrhea to the registered nurse. Diarrhea may be due to administering formula that is too cold or at too rapid a rate, lack of fiber in the formula, product contamination, or patient intolerance of specific ingredients. Administer the formula at room temperature at the rate ordered by the physician. Avoid contamination of the formula. If the problems with diarrhea continue, the physician may order changes in the formula or the rate of administration. The patient may experience dehydration. This occurs when the body receives too little fluids or loses excessive amounts due to vomiting, persistent diarrhea or fever, or certain medications such as diuretics, also called water pills. Symptoms of dehydration include increased thirst, dryness of the mouth, lips, or skin, weakness or fatigue, fever, weight loss, decreased urine output, or dark, strong-smelling urine. The patient should receive the correct amount of formula and water every day. Weigh the patient regularly and report a loss of more than 2 pounds in 1 week. Also report any diarrhea, fever, or vomiting. Now some questions about enteral nutrition. What is enteral nutrition? Describe your role. What is the difference between an NG tube and a G tube? What are 3 important points of care for the patient on enteral nutrition? How can aspiration be prevented? The 1960s was a fascinating decade with many memorable accomplishments. The Sound of Music is still enjoyed on videotape. The Mustang is still going strong, and the miniskirt shows up in all different lengths. But thank goodness the technology of the 60s has been replaced. With the pumps of the 90s, patients do not have to be in a hospital to receive infusion or enteral therapy. Agnes Brown is with her family, getting stronger by the day. Soon she will move back to her own apartment. John Williams Jr. will complete his antibiotic therapy in another week. He has kept up with his classwork and will graduate with his class. Agnes, John, and thousands more like them can be treated at home where they can enjoy life to the fullest quality possible with family and friends.